My name is Liron, and I want to show you how we resect FIGO type 3 fibroids hysteroscopically using dynamic pressure management. I was taught in residency that hysteroscopic resection is only good for the submucosal fibroids, FIGO type 0 to 2. No one dared to dig into the uterus for FIGO type 3 fibroids. When I started my FMIGS fellowship, I realized that even these fibroids can be resected hysteroscopically with a novel adjustment to a very traditional technique using the resectoscope and varied intrauterine pressures. The secret is utilizing the intrauterine fluid pressure dynamically to make the tissue do what we need it to do. We use high pressures for better visualization and very low pressures to make the fibroids come to us, because we really don't want to go digging in there blindly. As we decrease the pressure and deflate the cavity, the fibroids that are close to the endometrium get enucleated into the cavity and become visible and approachable for safe resection. We continue to decrease the pressure so the fibroids continue to rise until they are resected completely. Sounds interesting? Let me show you how we do it. I always look at the ultrasound when planning the surgery. You can see here this 4 cm pediculated fibroid arising from the fundus, definitely getting this one. But wait, in the posterior wall there is a 3 cm type 3 intramural fibroid that does not bulge into the cavity at all. This will be our challenge. So we start the case with a panoramic view of the cavity. I can see that the large pediculated fibroid right here and its anterior attachment to the uterine wall. I can also see some small seedling fibroids, but I don't see any fibroid abutting the cavity in the posterior wall. Now we will gradually decrease the pressure until it's under the mean arterial pressure. For this patient, it was 70. At that point, we will see some bleeding as expected, but we might also see some hidden fibroids. While monitoring the fluid deficit, we start with a resection of the obvious fibroid in front of us, decreasing the pressure to be right above the map to be able to see well, while minimizing the fluid extravasation. We use the resectoscope to pull out the fibroid particles under vision to avoid using forceps blindly in the uterus, risking perforation. If we get some bleeding, we increase the pressure and continue this dynamic process until we resect the fibroid entirely. After resecting the visible fibroids, we inspect the cavity while dropping the pressure 10 millimeters of mercury at a time. Sometimes some hidden fibroids will reveal themselves at that point. And here it is. Now we can see it. Here's the type 3 fibroid that is now bulging into the cavity, allowing us to resect it. So let's do it. Again, the idea is to let the fibroid come to us. So we decrease the pressure as we resect the fibroid. We can also try to pull the fibroid out of its pseudocapsule, making sure not to exceed that border into the myometrium. In order to promote the migration of the fibroids into the cavity, we administer misoprostol the night before the procedure so the myometrial contractions will assist in nucleating the fibroids. As we get closer to the myometrium, we decrease the pressure, allowing us to see the depth of penetration and the endpoint, that is the pink myometrial fascicles that you see right here. At the end of the case, we drop the pressure and inspect for any other unpredictable fibroids bulging into the cavity. The cavity looks clean of fibroids and the surgery is over. Now I can offer my patients hysteroscopic management for FIGO type 3 fibroids and avoid major surgeries. All I need to do is to use the intrauterine pressure dynamically and help the fibroids come to me instead of going to them.
I can't come to you.